an articulated arm can be used as a complementary
population, and then talk about a little bit about the results in the literature. So the transoral incisionless fundoplication, it's endoscopic fundoplication. It's somewhere between a 270 degree to 320 degree wrap. It's incisionless, and it's all intraluminal. Here's the device. As you can see here, it's a long device. The endoscope goes entirely through the device and comes out the other end. This is the working end. This is what's called the tissue invaginator. This goes at the distal esophagus. It's hooked up to a stopcock at the base of the working end of the device. You put some negative pressure. It holds on the esophagus, and then you push it down into the stomach, which invaginates the esophagus into the stomach. Once that little rim or lip is in the stomach, you grab it with this helical retractor, it's called. It's just a screw on a cable, and you pull it up into this tissue mold. And then you fasten that with the I-shaped or H-shaped Prolene fasteners. Here it is in a graphical form. You put the endoscope down. The device goes over the top of the endoscope. You come down, you take the tissue invaginator, or the esophagus invaginator, push it down into the stomach, close the tissue mold after you've pulled the tissue up with the helical retractor, and then you throw your fastener. Once you've thrown one, then you work your way around, and you throw multiple, and then you actually do a second row. Here you can see the back side. This is where the scope goes. This black knob controls the helical retractor. The blue knobs control the deployment of the fastener. This controls the tissue mold. Here's just a graphical representation of what you're supposed to have when you're done. And this is a cutaway view of what you can see. Here's the fasteners coming across here. This is just compared to the Nissen. So here's kind of what you have before you do the TIF, and then it's a little bit bloody here because this is just immediately while I'm still finishing up the case, but you can see here there's a lot more prominence of the lip here, or the fundoplication afterwards. And this is a stock photo from the Endogastric Solutions website. It's a little nicer. So here's the procedure. Oh shoot. Can we go previous? There we go. You can see retroflexed in the stomach. You come down with the device, and the device is relatively good size. And you can see here it barely fits in this patient. Then you have to close the tissue mold, which is straight when it comes around the scope. You then, after invaginating the esophagus into the stomach, you grab it with this helical retractor here, pull it up. After you've gotten a nice grasp by screwing it into the tissue, you pull it up into the tissue mold, and then you fire your fastener across. Now you repeat this process several times, as far around as you can go, which usually ends up being 270 to 320 degrees. And then the more fasteners you do, the better. The device comes with a load of 20 fasteners, and if you can use 18 or so, your results are better than if you only use half. Here's kind of towards the beginning of the process. It's not quite done, but you can see how it's starting to form here. And I didn't go through the whole thing, but you keep on putting more and more fasteners, and it gets more prominent as you go. So there are some limitations, obviously. This is not a neonatal procedure. That limb is tissue mold is an 8-centimeter length. And so we did our smallest patients for 25 kilograms, and you can even see on this patient there's a little bit of mucosal injury from closing that device, even though it's clear against this wall of the stomach. In order to fit down past the cricopharyngeus, you really need to be able to put a 54 French bougie past the cricopharyngeus. And so we usually put down the bougie just to make sure it goes smoothly before we put the device in. So as far as the literature, it is nearly all adult literature. And there's been a lot of studies, prospective study from 2008 with 86 patients with a follow-up with about 12 months showed that 81% of the patients discontinued their PPIs after the procedure. There was no reoperations for failure of the procedure, and there was a complication rate of approximately 4%. Those included pneumothoraces and one perforation. So review of the literature, again, adult review, but this time of 15 studies covering about 550 procedures, showed that discontinuation of PPIs at an 8-month follow-up on average was about 70%. There was a wide range here, though, 32 to 93%. And then there was about an 8% failure leading to reoperation. 40 Nissens and 5 redo TIFs is what they did across those studies. Complication rate was about 3.2%. And then there is one, really the only long-term follow-up is this by Testoni et al. In 2014, which included 50 patients. It included a 3- and 6-year follow-up on the same patients. And you can see here at 3 years, the patients who received the procedure had no PPI use. 53% of the patients had no PPI use at 3 years, and then there was a 31% only used half of the PPI use that they did pre-op, and then 16% continued to use daily PPIs just as they had before. Now at 6 years, interestingly, if you look at this, the no PPI use and the have PPI use kind of switches. 35% for none and half is 50%. So, whether this calls into question the durability of the procedure or not is, it's clearly kind of makes you wonder. However, the daily use stays the same, interestingly. 4 of the 50 had a Nissen secondary to failure, which again is 8%, which is pretty consistent throughout the literature. Complication rate was 4%, and that was 2 pneumothoraces from the procedure. The pediatric literature, unfortunately, has one single lone report. It's Chen et al., and it happened to be at the University of Michigan. And there's 11 patients in that study. We did not pick our patients for fantastic results. We used 45% of our patients already had Nissens and had failed their Nissens. The adult literature does not really include any failed Nissens. Mostly their adult studies excluded all patients that had failed Nissens. We had half of our patients that had failed Nissens. 9 of 11 were severely neurologically impaired as well, and the 2 out of the 11 that weren't neurologically impaired had a history of tracheoesophageal fistulas and esophageal atresia. On average, our age was a little bit high. That is both because you need a relatively large person to put the device down, and the other is we did have neurologically impaired patients. One was 28 years old, but again was only 30 kilos, so was of a smaller size. Our average follow-up was 8 months. In 10 of the 11, there were really no signs of reflux at the 8-month period or the average of 8-month period. 1 of the 11 had continued retching, which he had preoperatively, and because his patient comfort went to esophagogastric disconnect, although there was a normal pH probe after the ESOFIX and a normal upper GI as well. Our complication rate was 1 out of 11, and that was a hemorrhage at one of the fastener sites. It did require clipping endoscopically, and it didn't require a transfusion, but did stop. So this was a pretty short follow-up, unreported or not yet, not published. I did informally go back in a quality assurance and looked at some of our 5. These are now 5 to 7 years out. 2 more did reoccur and required operations. So 3 out of the total 11 we did now have required a redo operation. So actually, as far as our patient selection, we didn't do too bad, but again, this is 11 patients, and it's retrospective data, so clearly not very good, not a very good literature base to prove efficacy of the device. So in summary, it is, as far as advantages, it's a little bit less invasive than a Nissen, although a Nissen's not exactly invasive, hugely invasive, at least laparoscopically. It does, per the literature in the adult populations, avoids the post-op gas bloat, supposedly, and other symptoms you can see with the Nissen. It does have some reasonable success after failed miserable Nissens, and there are reasonable results in the population that haven't had a failed Nissen. Disadvantages, the results in the adult literature, it's clear they are not as good as Nissens. Nissens in the adult population are about 96% successful, and these are about 70%. The device is not really easy to use. It takes some learning to use. There's a lot of strong force that is needed, but you also have to make very fine movements when deploying those fasteners, and it's a little bit tricky. You do need large patients. You need at least 25 kilos in our experience, and it's not easy to take down if it fails. I've taken a couple of these down, and it's difficult. And the last one is the pediatric population is clearly not well studied. So thanks a lot, and if you have a question.